Several months ago, a colleague of mine who is in pain management and someone I respect significantly sent me an article that was from 2019 on postoperative pain control. It was devised by a task force of multiple physicians and providers from different specialties on recommendations for postoperative pain control. And there were 6 general recommendations, and let's go through those and then talk briefly about what we are trying to do to fulfill those recommendations. Number 1, post-surgical pain control should be individualized. Number 2, it should be multimodal. Number 3, it should be multidisciplinary. Number 4, there should be a decreased reliance on narcotics. Number 5, increased access to care. And finally, education. So let's talk about the individualized postoperative pain control. Each patient that comes through the practice has an opportunity to discuss postoperative pain control in the clinic and especially at the preoperative visit. Also right before surgery and then at the time of discharge. We have a post-surgical aftercare program, and there's opportunities to have ongoing discussion about pain control during the postoperative period. Pain control should be individualized. We do have some standard medications that we use, but not every medication works for every patient. So good communication with the team and the patient is imperative. Post-surgical pain control should be multimodal. And what this means is that you should take advantage of multiple different treatments, minimizing the risk but maximizing the benefit. So we like ice. We like to use a brace as needed. We have a focus on movement and walking and trying to not be afraid of movement. Tylenol, even though some people will say Tylenol doesn't work for me. Well, Tylenol might have a small benefit, but also has a very small risk. NSAIDs like Celebrex and ibuprofen can be used. We like to use a muscle relaxant. Most of the postoperative pain, I think, from spinal surgery is from muscle spasm, and a muscle relaxant can really help. We use narcotics, but we try to use them at the lowest effective dose and for the shortest period of time. Postoperative pain control should be multidisciplinary. We work with nurses and techs and physical therapists inside of the hospital. We also work with nurses and physical therapists outside of the hospital in the post-surgical aftercare. We've collaborated with the anesthesiologists and pain doctors, pharmacologists, and a variety of other people to develop our protocols around postoperative pain control. So I hope that having multiple people weigh in on and help our patients can help to control pain and also limit risk. We talked already about the decreased reliance on narcotics. By using a multimodal approach and using narcotics at the lowest effective dose and for the shortest duration of time, we limit our narcotic usage. Most of the patients either don't take narcotics at all or take them for a short period of time. And this is an ongoing conversation to have with the team. But if possible, wean off the narcotics soon after surgery as your first priority in scaling back the pain control measures. Next is increased access. This is a challenging one with busy practices, but we try to have our nurse practitioners available and our surgeons available 24/7, and then the post-surgical aftercare people, the nurses and physical therapists, are also available most of the time. That gives our patients the opportunity to reach out and say, I'm in pain or I'm having an issue, and to try to resolve it. One thing that we want to be careful about is anytime a phone call comes in and the patient says, well, I'm in pain, we need to not just jump to, well, take more narcotics or here's another medication, but try to find out the root cause of that pain. Is it pain down the leg? Is it pain in the back? Is it normal for you to be having this type of pain? Or is this something that we need to go and investigate? Finally is education, and I have a strong interest in education. I think that we fail in medicine oftentimes in the transactional environment that we're in. There's not a code for educating in the scenario that we're in, and so education is often missed. One of the reasons to do these videos on a regular basis is to help promote the idea and concepts and understanding to the patients so that they have the best understanding possible about their problem and about the treatment. Education on pain control is a very important thing so that patients can maximize the treatment and minimize the risk. So again, the recommendations are individual, multimodal, multidisciplinary, or decreased reliance on narcotics, increased access in education. And we are striving to meet these recommendations by the Health and Human Services Task Force.